Hello, my name is MarkAlain Déry. I'm an infectious diseases physician and epidemiologist here in New Orleans, Louisiana. Despite significant progress in HIV prevention and treatment, disparities persist across different populations. This roundtable that we are going to have today brings together three distinguished HIV experts and stakeholders to examine the complex factors driving these inequities and explore strategies to promote health equity. By fostering open dialogue and collaboration, we aim to identify actionable steps to address HIV disparities and ensure access to quality care for all affected communities. The insights and perspectives that our experts will provide here today will be invaluable in shaping a more just and inclusive response to the HIV epidemic. And with that, let me please introduce our three panelists today. First up will be Dr. Monica Gandhi. She's an infectious diseases physician and professor of medicine and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the UCSF School of Medicine. Dr. Sneha Jacob is an associate professor of medicine at Rutgers University, Robert Wood Johnson Medical School, as well as an HIV specialist with a background in internal medicine. And Dr. Hamadullah Shaik is an assistant professor in infectious diseases at Rutgers University, Robert Wood Johnson Medical School, and is associate chair for infection prevention at Robert Wood Johnson. Please, let's give our panelists a warm welcome. How can healthcare systems and policies be improved so that it can better support and promote HIV prevention efforts such that our patients don't have to get off of their healthcare just so that they can access some of these Ryan White services that are really geared for people living with HIV?
So I think having better dissemination of information, probably also within the provider community, I think is important. I think sometimes we're preaching to the choir when we're talking among HIV and infectious disease providers. And if you look at the sites we represent, we are groups of people who know quite a bit about PrEP and prevention. But here in Central Jersey, we had done a large-scale survey of the South Asian community, who we have a large population of, partly because we were seeing South Asian patients with HIV, but also to look at the physician community to see how often they are prescribing PrEP and also how often they're screening for HIV. And we did find less knowledge or less common screening and PrEP prescribing, particularly among physicians who'd been in care longer or been in practice longer. And even when I get a newly diagnosed HIV patient who's been in primary care prior, my first question is, especially if it's a young gay man, is, have you ever been offered PrEP? And there are many patients who may have heard of it, but had never had that discussion with their physician and would really need to go and actively seek it. And so I think the provider community being more aware, and that I think can also impact policy and advocacy on a policy level and on a health insurance level. I think that's critical.
Thank you so much, and really very insightful. And yes, I think awareness is so important, especially when it comes to provider awareness. But I think, I get the sense that at least some of my colleagues, at least here in New Orleans, we're better. I think we're better off with respect to PrEP awareness and HIV awareness, and I think that we've been, certainly I feel like I've been ringing this bell for 10, 15 years, but it seems like that the ring is finally getting into people's ears, fortunately. So as we kind of pivot in,
and I just interrupt and say one thing based on what you just said, because I think that's really interesting. That the one thing I keep on comparing this to is contraception. Like when OBGYNs gave out contraception only, it was pretty limited. And then when the primary care provider, the ER provider, the urgent care provider, started acting like that was within their purview, which it is because it's preventative health, then we had better uptake. And it feels like with PrEP that it can't be ID physicians, it can't just be HIV doctors, it has to be where it's taken across by primary care physicians, where they see it as part of preventative health. And I think there's been this concern that you have to do monitoring with TDF, FTC, renal, and so forth, but it's not very onerous. And with IM cabotegravir, there's hardly anything in terms of monitoring. You just need to do HIV testing. So I would really encourage that constant discussion of the primary care provider having really take this on.
So kind of along those lines then, something that you mentioned when we first started the discussion is, can you talk about how socioeconomic disparities such as poverty and lack of access to healthcare can affect an individual's ability to obtain some of these HIV preventative measures that we've been talking about? And how do you in either your healthcare system or your clinic address those issues?
Yeah, so I mean, it's really interesting to think about what the adherence barriers are actually across the planet. So I would say I've done work in India speaking to Dr. Jacob and the South Asian community, and stigma is a huge barrier to uptake of HIV medications. And they actually don't even encourage HIV prevention yet, but every place is different. Country, population, stigma, big one internationally. Stigma is definitely still here, of course, in the United States, especially again among MSM, mainly who are from racial and ethnic minorities who may not want to disclose their particular sexual orientation. And so stigma is still there, absolutely. But what we've seen in the urban centers here more in the United States is that overlap of substance use, which of course worsened during the pandemic and is still very much with us. Overdose deaths account for, they are the #1 cause of death among those 45 years and younger in the United States. And here in San Francisco, overdose has surpassed any other cause of death for people living with HIV. So substance use, very big barrier to taking a pill every day in adherence. And then depending on your urban center, and we are somewhere that's where we really have a very big problem with homelessness and not having housing security. And then mental health concerns also rose during the pandemic. So all of these together, I think, are the barriers in urban centers, but stigma is still pervasive, sometimes forgetting, sometimes stock out, sometimes transportation, childcare, don't want to have people see your meds. There's lots of these barriers to adherence. So these are the structural determinants. These are the structural issues in getting on prevention and treatment. And the things that we've tried to do about it is we can't provide housing for everyone. We wish we could from our clinic. We advocate for housing, certainly, but what we do is we have a program called Pop-Up. And our Pop-Up program at Ward 86 is exclusively for those who are homeless and who don't have virologic suppression. The Pop-Up program is, the entire premise is low barrier access. You can come in anytime. No appointments are necessary because that can be really hard when you're living in a tent. And you come in and the same team forms around you. So there's that continuity of the same social worker, nurse, same small group of providers. We will do whatever you want in terms of what you're coming into the clinic for, in terms of an urgent care problem, but we will also do primary care provision, vaccines, try to get people on antiretroviral therapies, and we do provide economic conditional incentives for getting on antiretrovirals and getting virologic suppressed. And we combine substance use treatment with that, especially really excited if people are willing to do the long-acting, because we are using long-acting ART a lot in our homeless population, and we'll try to pair those with substance use treatment. So lots of incentives for that as well, like clean urines, or at least cutting down on drugs. So that's one way that we've tried to address those living with homelessness, which is overlapping with substance use. And then substance use, trying to just raise awareness that we do have treatments, not the most amazing treatments for methamphetamine, which is actually more of our drug of use here in San Francisco compared to some areas in the East Coast. But we're still trying to get everyone on substance use treatment who's willing. And then finally, in terms of mental health, we've actually been really interested in the long-acting antipsychotics, and again, paired with long-acting antiretroviral treatments. But the biggest strategy we've been using is kind of bold because it's not approved, using long-acting antiretroviral therapies in those who are viremic, in those with adherence challenges, and those who are homeless. That has been the biggest game changer that we've seen over the last 2 years. Luckily, because we have medicated, we can get these long-acting cabotegravir and rilpivirine, and it's been really, really quite successful.
And I think, that's amazing, and thank you for that. But I think probably one of the key things that I heard there was something that I've done in my clinic as well, was that you've removed obstacles for getting somebody seeing a case manager or seeing a provider, because I think we've all identified that those obstacles were, and I didn't even realize they were there. They were just part of the structure of medicine. But it wasn't until we started doing same-day start or rapid start made me realize, oh, these obstacles I just need to be available, or I need to have somebody available. I'm the only infectious disease person in a large 50 clinic Medicaid providing clinic system throughout the state of Louisiana. And when there's a positive HIV, I get a text, and within 2 or 3 minutes, no matter where I am, I'm doing a virtual visit with somebody in one of those clinics. And so just from even our perspective, it took a while to get people to understand the importance of separating yourself from the way medicine used to run, such that we
Low
remove
barrier.
those
Yeah.
obstacles 100%. And that's what I heard there. And I think that's just amazing work.